Thank you for joining us this evening. Tonight's webinar will be given by Dr. Jake Schroeder, one of our sports medicine surgeons here at Rothman Orthopaedics. Dr. Schroeder sees patients in our Bensalem, Doylestown, and Chalfont office locations. Those of you who have joined our webinars before, you know to enter your questions in the Q&A box at the bottom of your screen, and Dr. Schroeder will take time at the end to answer as many as we have time for. So, Dr. Schroeder, you can take it from here.
All right, thanks. Um, Thanks everybody for coming. Really appreciate taking the time to spend some time with us tonight. Going to give a talk entitled Modern Advances in Knee Arthritis Treatment, Understanding Your Options Before Knee Replacement. I know obviously there's a lot of things you could be doing tonight, so I'll try and make this as useful and as practical as possible. What I'd like to do today is kind of walk through how we think about knee arthritis, and more importantly, how we decide what the right treatment is. One of the biggest challenges in treating knee arthritis is that there isn't just one simple answer all of the time. Two patients can have, very similar X-rays, very similar symptoms, sometimes very different symptoms. They can have different goals depending on, stage of life and expectations. So it's not just a one-size-fits-all type situation. So the goal tonight is not just to list options, but it's really to give you a framework so that you can better understand where you might fit along the spectrum. So just briefly, these are the objectives for the talk. We'll start by talking about what knee arthritis actually is and how it actually develops. Then we'll go through the full spectrum of the different treatment options available to patients. We'll spend some time on what I think is the most important group, patients that kind of fall in this middle category. Maybe it's not the most severe arthritis, but it's still, symptomatic and affects your day-to-day activity. And then we'll give you a framework for choosing the right treatment for you. And we'll touch on some kind of new emerging options to help bridge this treatment gap. So starting with the basics, what is knee arthritis? At its core, it's a degenerative process that involves the loss of cartilage, which is kind of the smooth surface that allows the joint to move without friction or very little friction. It's kind of what you see on like chicken bones, kind of the smooth part of the chicken bone. That's kind of the cartilage, kind of what it looks like inside your knee. But it's really important to understand it's not just the cartilage. There's also changes in the underlying bone. There's changes in the meniscus, which kind of functions like a shock absorber or a gasket between the bones. There's changes to the synovial tissue, which is kind of the tissue that lines the joint and helps to nourish the joint. So it's really a whole joint problem. It's not just a cartilage problem. Over time, as this develops and worsens, this is what leads to pain, leads to stiffness, swelling, and ultimately decreased function. So that's why patients often come in and they say things like, my knee feels very stiff, or it aches after activity, or it's harder to get moving after sitting for a prolonged period of time. These are all kind of common patient complaints after development of arthritis. We'll kind of touch on it, but it most commonly affects kind of the inside part of the knee joint as well. You can kind of see on this X-ray here how there's loss of space on the inside of the joint relative to the outside of the joint. And that's typically where patients will experience most of their symptoms. We can't really see, the soft tissue on X-ray. We can just see the bone, and we can kind of infer that with the loss of space between the bone, that's what's causing the arthritis. So why does arthritis develop? There's a number of factors that contribute to arthritis. Age is certainly one factor, but many patients develop symptoms earlier than they would expect. Prior injury is a major factor. Things like previous meniscus tears, ligament injuries, previous fractures that go into the joint can all help contribute to the development of arthritis. And even though those injuries seem to heal at the time, they can really change how force is distributed throughout the joint. So it can, have, effects down the line, maybe 20, 30 years after an injury, you might feel the effects of arthritis. Alignment is also very important. If someone has a little bit of bowing to the leg, we call this a varus alignment, that increases the load on the inside of the knee. And over time, that extra load leads to wear. Conversely, you can have valgus alignment, which is kind of the knock-knee alignment, and you would kind of wear out on the outside of your knee. There are also factors like body weight. More weight means more force across the joint. I have to tell patients that, when navigating stairs, your knees can see 7 or 8 times your body weight. So this kind of creates a little bit of a vicious cycle. It's oftentimes a difficult conversation to have with patients that, one of the most effective ways to make your knees feel better is actually to lose weight. And your knees will actually see less force and your pain will improve. Obviously, activity plays a significant a role in development of arthritis, and obviously, genetics is also something that plays a role. Some people are just more prone to developing arthritis, and you can thank your parents for that. So it's pretty much just an accumulation of wear and tear throughout one's life. So for most patients, it isn't just one thing; it's usually a combination of multiple things. Probably one of the more important concepts is kind of how arthritis progresses. And what happens as arthritis progresses is that the cartilage that we talked about begins to really wear down. As that happens, the force across the joint becomes more concentrated. At the same time, the meniscus, which we said usually functions like a shock absorber, that can also start to degenerate. So now you have less cushioning, more stress that goes through the joint, and this is that cycle that we were talking about. Kind of creates a vicious cycle of pain. More stress leads to more cartilage loss, which can lead to more stress, and that cycle is really what drives both the progression of arthritis and the symptoms that patients will feel. So when patients say that their pain is getting worse over time, it's often because of the cycle. I often tell patients that arthritis is a progressive condition. It's going to get worse with time, not better, but we can't always predict at what rate this progression occurs. So for some people, it's very rapid. Other people can simmer for many years and can be tolerable. So everybody's different. But importantly, most of our treatment are aimed at breaking this cycle in some way. So we mentioned this, most arthritis occurs on the medial or the inner side of the knee. And that's because even in a normal knee, about 60 to 80% of the load goes through the inside part of the knee. So if someone has even a little bit of bowing, like we said, this increases that load, which contributes to that cycle. So over time, the inside tends to wear out first. And that's why many patients feel pain primarily along the inside of their knee. And like we said, you can also have a malalignment that would cause development on the outside of the knees, although that's a little less common. So before we really talk about treatment, I think it's important to take a step back and really think about what patients actually want. Most patients don't come in to the office asking for a knee replacement. Most of the time, they come in asking how they can avoid a knee replacement. They come in saying things like they want to keep walking, they want to keep playing golf, pickleball, etc. They want to play with their kids, they want to stay active with their family. But oftentimes patients don't feel like they're ready for a major surgery or, life gets in the way and they don't have time for a big surgery. And that's really, the challenge. Historically, our treatment options haven't always matched up with, patients' goals as effectively, I think, as we would like. Typically I like to think of treatment as a spectrum. On one end, you have conservative options, modifying one's activities, medications by mouth, physical therapy for strengthening, a variety of different bracing options, a variety of injections. And then on the other end, you have, more invasive procedures like a joint replacement. In between, you have some procedures that we'll try to preserve the joint or try and change how these forces are distributed across the joint. So most of today's discussion is really about kind of that middle ground. Non-operative care is always where we start. Physical therapy focuses on strengthening the muscles around the knee, which can help improve stability and hopefully reduce stress, almost functions like a shock absorber. So that's usually where we start. Like we mentioned, weight loss can also have a very significant impact. Each pound loss reduces, multiple pounds of force across the joint. And then, injections, cortisone injections, viscosupplement injections like gel injections, even PRP injections. can help reduce inflammation and help make patients feel better. So these treatments obviously play a very important role, and they definitely help many patients, but they certainly come with some limitations. The limitation is that these treatments are addressing symptoms, not necessarily the underlying mechanics of the problem. They don't change how force is distributed across the joint. So what we often see is that patients improve for a period of time, but then they eventually plateau and aren't getting the relief that they're seeking. A common scenario, patients come in, they have repeated injections, they have some diminishing returns, and over time they become less effective. Oftentimes they say it's just a band-aid. It's not actually treating the problem. And I think it depends on your perspective. And is the problem the pain, or is the problem the arthritis? And I think most of the time patients are coming in because they have pain and ultimately they want to feel better. But again, oftentimes these options aren't durable. They don't provide long-lasting relief. And that's when you begin to talk about other options. So how do we treat this problem then? There's a few main strategies. We can try to unload the joint, for example, using braces. This picture is of an unloader brace, and it's kind of an old school way to treat malalignment and to deal with arthritis in a non-invasive way. I have some patients that use this quite effectively. They have specific activities. They like to go boating, they like to go hiking, and when they wear this brace, they often feel better. But it is sometimes difficult to tolerate for long periods of time. It's big and bulky. You oftentimes can't wear it under pants, so it has some limitations. We can try to realign the joint, such as with procedures like osteotomies. They're probably less commonly performed today than maybe in the past. But the concept is to realign the joint to help improve load distribution across the knee and improve pain. Usually this was a procedure to kind of help buy some time until somebody needed a knee replacement. It's a pretty invasive procedure. It comes with a period of non-weight bearing during the recovery, which patients don't usually like. But it does come with less restrictions for activity. Some patients can be quite active after this procedure, sometimes more so than a knee replacement. And then we can also replace the joint. So knee replacements are probably considered the gold standard for treatment of osteoarthritis that have failed other conservative options. It's very, very good option, has excellent outcomes. Historically, not quite as high from a satisfaction standpoint compared to like a hip replacement, for example. Also comes with surgical risks and some activity limitations. You're not able to really run marathons or aggressively run 5Ks, for example, on a knee replacement, but it does effectively treat pain from arthritis. And then we can try to reduce the load going through the joint. So this is the last concept where some of the newer approaches come in. So again, knee replacement, excellent option, a very durable pain relief, has very good long-term outcomes. Usually tell patients satisfaction is around 80 to 85%. So you can do everything technically correct from a surgical standpoint. Patients can work very hard from a physical therapy standpoint, do everything correct. But there's still probably going to be about 15% of people who end up dissatisfied in some way. I think a lot of this has to do with expectations. It's not really meant to make somebody feel like they're 20 years younger or really return to high impact activity like running. But it does excel at realistic pain relief, return to lower impact activities, walking, tennis, pickleball, etc. But it's not really a lifetime solution. So people who are a little bit younger, usually try and have them delay as long as they can because there are some durability concerns. And like any surgery, it comes with risks. Probably the worst risk, the most concerning risk with a knee replacement is infection. And that can be really devastating and oftentimes requires multiple surgeries, almost salvage type procedures that come with poor outcomes. So again, when possible, we try to delay it until patients are a little bit older and maybe a little bit less active. So again, this kind of brings us to the concept of load modification. So if the problem is really that there's too much stress going through a damaged part of the joint, one solution might be to try and reduce this stress. I think it's a pretty intuitive concept. This is a mechanical problem and potentially could have a mechanical solution. And importantly, I think there are ways that this can be done without cutting bone or replacing the joint. So again, this frustrating middle, this is really a group of patients I think about, probably the most in my practice that I see. Patients that have done all the right things. They've done physical therapy, they've worked on strengthening, they've tried injections, sometimes, multiple injections over several years, but they're still having pain. They still feel limited. They can't do the things that they would really want to do. They can't walk as far as they used to. Stairs are difficult. They can't play golf, tennis, they can't run, or they've really had to stop, you know, altogether doing these things. And many times this can be incredibly frustrating. And oftentimes patients feel like they're not ready for a knee replacement, or they're too young for a knee replacement, they're too active for a knee replacement. So they kind of get stuck in this kind of in-between gray area where the symptoms are too symptomatic to ignore, but they're not quite ready for a knee replacement. Like I said, very difficult place to be in. And we haven't historically had really great options for these patients. We often tell them to keep on dealing with it until it's too much, come back when they're ready for a knee replacement. But sometimes that doesn't work for some patients. That's not an acceptable option. So what else do we have to really offer them? How do we potentially reduce their pain, improve their function, maintain activity without jumping straight to a knee replacement? And again, this kind of goes back to the idea if there's too much stress going through the damaged part of the joint, then one, logical solution might be to try and reduce this stress. So again, common patient scenarios, patients 45 to 65, they're very active, but they feel limited. They come in, they're complaining of pain. They can point to say, hey, it hurts right here on the inside part of the knee. They might have seen another provider. They might have had imaging. They might have been told that hey, you probably have a meniscus tear. It's probably a degenerative meniscus tear. They've tried, conservative options, but, they're not quite at the stage for a knee replacement. So, I mean, there's some estimates that, up to 15 million people in the United States deal with knee arthritis. So, there's a lot of people out there that kind of fall into this kind of middle gray area that are kind of looking for options. So again, common scenarios, degenerative meniscus tears. We often see this situation in these patients. It's really a marker of overload. It's very common for patients to come in and say, "Hey, I have a tear. I need to get it fixed. I need a knee scope." But there's a lot of studies now that show, a knee scope for a degenerative tear, meaning you haven't had an acute injury, but you have pain and you have an MRI with the tear. It's not really an effective treatment. Patients often do just as well without surgery. Sometimes they do even worse with surgery. So it's not really, the best option. The reality is there's really no way to differentiate pain from a meniscus tear versus pain from knee arthritis. And they're oftentimes occurring simultaneously. So the meniscus degeneration is just kind of part of the wearing out process of the knee. The problem isn't really just with the meniscus. It's really, again, back to the load going through that part of the knee. So treating the meniscus doesn't really solve the underlying issue. Another common scenario is bone marrow edema. This is essentially a stress reaction within the bone. It's representative being meniscus deficient, meaning that the meniscus isn't absorbing stress appropriately. And as a result, the stress gets passed on to the bone. You develop fluid in the bone, and it's almost like a bone bruise. It can be quite painful. These findings really correlate very strongly with pain that patients experience. And again, it's reflective of mechanical overload. So once again, the underlying issue is load. And these are very, challenging situations to treat. We haven't historically had a great option outside of, completely staying off of it, bracing, or a knee replacement. So this comes to the idea of implantable shock absorber. So if we take a step back for a second, we just talked about what's actually driving symptoms in these patients. It's not just cartilage loss. It's that there's too much stress being concentrated in one part of the joint. So the question becomes, can we reduce the stress without replacing the joint? And so one way to do this would be through load absorption. It's actually a pretty simple concept. If we can decrease the amount of force going through the damaged part of the knee, then we may be able to reduce pain and hopefully improve patients' function. Importantly, we can do this without cutting bone or without replacing the joint. And again, this is where this implantable shock absorber concept comes from. It's a device that sits on the outside of the joint, so it's considered extra-articular. It's positioned along the medial or the inside part of the knee where most of the load tends to be concentrated. And what it does is help absorb some of the force during activities such as walking or running. So every time you take a step, there's a certain amount of force that goes through the knee. In a normal knee, the force is distributed relatively evenly, but in arthritis, again, becomes more concentrated. And this device is essentially helping to share some of that load. It compresses a little bit as you walk on it, and in doing so, it takes stress off the overloaded compartment. There are studies that show it takes about 30 pounds of force off of the inside part of the knee. So if you think about like a car tire that's wearing out unevenly, if you keep driving on it, it's going to wear out faster and faster. But if you get, the tires realigned, you redistribute the load, you can slow down that wearing out process. And that's kind of a similar idea. We're not really fixing the cartilage, but we're just reducing the stress that's going through it. So it's important to be clear about what this is and what it isn't doing. It's not regenerating cartilage. It's not reversing arthritis. It's just kind of modifying the environment of the joint. Again, reducing stress and hopefully improving pain. I think it's very important to think about patient selection. This is not a device for patients with really advanced diffuse bone-on-bone arthritis throughout the entire knee. It's mostly designed for people in the middle group, more moderate arthritis, mostly on the inside, people who want to maintain activity. They've already tried conservative treatments. Expectations matter. This isn't like a panacea. It's not going to make you feel like you're 20 years younger, but I think in the right patient, it's going to provide meaningful improvements. It can potentially delay the need for a joint replacement. There's really good early and midterm data showing improvement in pain and function in the appropriately selected patient. And again, it's something that we're continuing to learn more about over time. So again, you can see the size is relatively small, relative to a quarter. Let's see if I can. This video, you can kind of see in a lab how it functions. It really is functioning like a shock absorber. So again, the ideal patient, very important to have appropriate patient selection. Pain that's really focal to the inside part of the knee, patients who have failed conservative treatment, and they really want to maintain activity. I think that's one of the most appealing parts of this is there's really no activity restrictions. There's case reports of patients returning to running marathons, playing, recreational sports at a high level. Whereas with a knee replacement, for example, you really can't do some of those really physically demanding activities. So who's not a candidate? It's like I said, not a solution for really severe advanced arthritis, where you have arthritis throughout all three compartments of the knee or tricompartmental arthritis. It's not for patients with significant deformity. You can see these X-rays. This is somebody who has, severely knock-kneed. It wouldn't be for this type of patient. Some patients have inflammatory arthritis, like rheumatoid arthritis. Again, not designed for those types of patients. And you can see here some studies they've done. They've excluded patients that have severe arthritis on the outside of the knee, severe arthritis behind the kneecap, or patients with significant alignment issues. So again, for recovery expectations, I think, again, one of the biggest advantages is recovery tends to be a little bit quicker than more invasive procedures. Patients are typically weight-bearing right away. They can return to activity more quickly. Again, it's still a surgical procedure, so there's going to be some recovery, but overall, it's going to be relatively more quick than more invasive procedures. And again, this concept of returning to activity without restriction, I think, is very appealing to a lot of patients. That maybe you wouldn't be able to get back to some of these activities if you had a knee replacement, for example. Here's some videos. Immediately right after surgery, patients can bear weight. We encourage them to do so. Early physical therapy is important to regain range of motion. So this is, pretty encouraging. And then, shortly after surgery, is the patient about 10 days out. This is a very different type of presentation than a lot of patients who have a total knee replacement 10 days out. They're still kind of struggling to get around, usually still using a walker. So again, I think hopefully a quicker recovery with this procedure. What does the evidence show? Again, early midterm data is very encouraging. In the appropriate patient, they're having excellent outcomes. All of the patient surveys that they do, there's a clinically meaningful pain improvement that's lasting up to 5 years out from the date of surgery. So, there is some durability. We don't have really long-term data, but there has been some iteration of this device that's been implanted for 10 to 15 years. So some patients have had it for quite some time. You don't really burn any bridges with this. I think that's another concept that's important. Some patients don't like the idea of getting a knee replacement because it's permanent. You know, you're permanently altering your anatomy. This still preserves the option of a knee replacement in the future, for example. It's really kind of intended for this middle ground that we were talking about between conservative care and a joint replacement. And then some patients just are really very adamant that they don't want a knee replacement for whatever reason. They have personally had poor experiences, a loved one has had a poor experience, and they're just looking for alternative options. So again, some important to be honest about what we still don't know. We still don't have really true long-term data like we do with the knee replacement. Like I said, it's been around for 10 or 15 years with some modifications, but knee replacements have been around for decades. We're still trying to define exactly which patients benefit the most. They're doing more and more studies. My understanding is they're coming out with more studies later this year, kind of comparing it to different treatment options. There's some national societies that are involved in some of the studies to help determine, specific guidelines for providers to know who is going to benefit the most. So, I think it's exciting that these are going on, and hopefully we'll have more information, in the next couple of years to kind of help guide some treatment. So again, this is kind of how I like to frame things with patients. This table, on the one end, you have your lower risk options that are often temporary, your physical therapy, your injections. At the other end, you have knee replacement options, again, very effective, but more invasive. And then you have, options in the middle. You have maybe this load absorption device, osteotomy procedures, partial knee replacements. And really the goal is to match the treatment to kind of where you are on the spectrum. So kind of just, typical example, hypothetical patient, somebody who's active, 54, they come in, they have pain on the inside of their knee, they failed injections, they failed therapy, they want to keep running, but they're kind of nervous about a knee replacement. What would you do in the situation? Again, you can continue conservative treatment. You could do, the shock absorption device. You could consider an osteotomy. You could do a knee replacement. And this is the type of thing that we would kind of talk about in the office to help try and figure out what aligns most appropriately with kind of your goals. So just kind of to wrap up, knee arthritis isn't a single problem with a single solution. It does exist on a spectrum. And, the most important thing is not really choosing the newest treatment or the most aggressive treatment. Hopefully, it's choosing the most appropriate treatment for, the right patient at the right time. And in many cases, that means finding ways to stay active, manage symptoms, and potentially delay bigger surgeries until it makes sense. So, the goal is not really to treat an X-ray or to fix an X-ray, but it's really to help patients get back to doing things they enjoy. So, again, it's a spectrum. There are options kind of for that middle ground, I think, that are exciting. And I think it's important to understand kind of what options are available to you. And that's it. Questions?
Thank you. Yeah, we have a bunch of questions coming in. I could kind of read them over to you, Dr. Schrader, if that's good with you.
Sure.
All right. First question, is knee decompression a valid treatment option?
What, knee decompression?
Knee decompression.
Um,
I don't know exactly what they're asking there.
yeah, I'm not entirely sure what that would be, a decompression.
All right. If you want to send in a follow-up question for that, um, to exactly what you're asking. Next question. How long does a cortisone shot last?
So you usually tell patients you don't know until you try it. Some people can last for, many months, 6 months to a year. I'd say that's probably on the longer end. On average, is probably 2 to 3 months. Some people get very little relief, so it's really one of those things you don't know until you try.
All right, thank you. Couple questions about Voltaren. I see a few actually. This person said they've tried Voltaren and diclofenac. Am I
Mhm.
saying that right? 2% with poor results. Tried every type of injection with poor results. Is there anything else to try besides a knee replacement? And then a couple people just asked, what are your thoughts on Voltaren?
Yeah, I mean, I personally use Voltaren. I tell patients all the time I like to play basketball on the weekends. I don't play as much as I used to, and I use it on my back all the time. It's pretty effective for me. In terms of options, I think we kind of went through. kind of the treatment algorithm and kind of options available to you. But you can do injections. There's a variety of injections. You can do gel injections, steroid injections, PRP injections, therapy, bracing, and then some of those more invasive options that we talked about. And then the most invasive would be a knee replacement.
All right, thank you. Can you talk about subchondroplasty done with a meniscus repair?
Yeah, so subchondroplasty, I feel like it's kind of fallen out of favor a little bit. It's an option. Maybe that's what somebody was getting at about the decompression. It's kind of an option for, patients that have subchondral edema or this fluid in the bone. And you kind of inject almost like cement. You kind of vent that area, release some pressure, and then you reinforce it with cement. Um, it's not something that I do commonly, but it's certainly an option for the right patient. So I mean, that's another treatment option for that type of problem.
All right, thank you. Couple of questions about your thoughts on PRP or stem cells.
Yeah, so I was just talking to somebody today in the office actually. I think stem cells, that concept I think is misunderstood by a lot of people. So I think most people, when you think about stem cells, you think about like embryonic stem cells, which really is not a thing in the United States. Um, PRP or drawing out like bone marrow and spinning that down or fat and spinning that down. They're kind of types of stem cells, but they're mesenchymal stem cells. So um, they really work to limit and reduce inflammation. It's not really regenerating tissue. I think people think a stem cell, you're going to regrow cartilage, and that's really not a thing. So I think it's kind of misunderstood. I think PRP will become more common as more studies come out and insurances pay for it. It's still expensive. So I personally have a tough time like looking patients in the eye and say, hey, do this thing that costs like $1,000 and it might be a little bit better than a steroid injection. But I think over time, it'll probably become more common. I think patients like the idea of using their own cells rather than, a drug.
All right, thank you. On injections, there's a couple different questions about cortisone versus gel injections. What's the difference, and do you recommend them?
Yeah, so certainly a lot of patients that have them that do well. Steroid injections work by reducing inflammation. Patients always ask like, there's concerns with damaging cartilage, and I think there are theoretical concerns. I'm not really aggressive recommending injections for people who are younger who don't have arthritis, but kind of once you have arthritis, cat's out of the bag a little bit, and even if it might damage the cartilage a little bit, the cartilage is already pretty damaged. As far as I know, that's never really been like definitively proven in knees. There's some studies for hips that it can maybe cause some rapid degradation of cartilage. So that's certainly a risk. Gel injections, I'm convinced nobody fully understands how they work. It's usually described like a lubricant. So you're lubricating the joint. I think there's some thought that, maybe it encourages healthier cells in the knee to produce healthier fluid. There's maybe some thought that it also has an anti-inflammatory effect, but again, it's one of those things that you kind of have to try to know, does it work for you or not? I have some patients it works very well and other patients that it really doesn't do anything for.
All right, thank you. Several questions about the shock absorber option. Um, is it covered by insurance? That's one of the questions.
Yeah, so it is a newer procedure. So my understanding is that from like an insurance standpoint, they're coming out with a CPT code January 1st of 2027. So I think it'll be a little bit more, it'll be easier to have insurers pay for it at that point. My understanding is you have to kind of have to go through an appeal process, and there are resources available for that. I'm pretty sure Medicare pays for it. And then beyond that, I think each individual insurer kind of depends on, what treatment that you've had previously, and kind of the specifics of your insurance. So it's something that you certainly have to look into before you actually have the procedure, but there are resources available to do so.
All right, thank you. Lots of questions coming in. Can you share who the manufacturer of the shock absorber device is? Someone asked.
Yeah, the company's called Moximed.
Okay, great. There's tons of questions. So many good ones. Let's see. I have swelling off and on the outside of my knee. Does ice or heat work for inflammation? Also, when I ride my bike, my knee feels better. Am I doing more damage by riding the bike?
So personally, my biases usually recommend ice. Some patients will say they feel better with heat. Heat can sometimes cause worsening swelling, kind of increases blood flow. So ice kind of does the opposite, reduces inflammation. So usually my bias is to recommend ice, but ultimately it's whatever works best for you. I think stationary bike is a great low impact activity. Um, it's always a little bit of a trial and error trying to figure out how much activity is enough. We want you to be relatively active, but we also don't want you to do too much and overdo it. So usually encourage patients to like mix up their activity to avoid kind of overuse issues. Don't do the same thing over and over. Like don't go for a 4 mile walk every day. Maybe go for a walk a couple days a week and hop on a stationary bike a couple days a week, hop on an elliptical and kind of change things up. But I think a stationary bike is a very good option.
All right, thank you. Couple questions about Baker cysts, if there's connections between Baker cyst, arthritis, and knee pain, and do repeated Baker cyst aspirations exacerbate arthritis?
Yeah, so Baker cyst, very common to see patients in the office that come in because they have a Baker cyst or a Baker cyst was found on MRI. Usually the Baker cyst itself is not something to be really that concerned by. It's usually more representative of something else going on in the knee. So whether that's arthritis or a meniscus tear, it's representative of like a small rent in the joint capsule and fluid can leak out, kind of creates a one-way valve, creates this cyst, and it can't get back into the knee. So, if you address the underlying issue, inflammation in the knee joint, usually the Baker cyst kind of subsides as well.
All right, thank you. Oh, this person said they asked the question about knee decompression. They had 21 sessions of knee decompression, which is computerized traction to create separation in the knee joint. It has reduced this pain. Do you have any opinion on that?
I'm not, I don't know much about that. I don't have any personal experience. I mean, it sounds almost like, there are traction tables, kind of old school for like back pain. And, that, at least for back pain, people typically feel good when they're doing it. And then over time, the improvement kind of goes away. So I'm not aware of that being something that's kind of widely adopted for knee arthritis. But again, I'm always open and willing to learn new things.
Right, thank you. See. This person said they have bone-on-bone arthritis in their knee, but they're not experiencing that much pain. Should they address the knee now or wait until there's more discomfort? Their other knee has already been replaced.
Yeah, I mean, I usually tell patients, we don't treat X-rays. So, X-ray findings are just a piece of the puzzle. It's not the whole puzzle. So if you're really not having pain, then I probably wouldn't do a whole lot about it.
All right, thank you. All right, this person said they have chondromalacia patella. They don't have an issue walking, but any jumping or running, it gets worse. They often feel pain on the lateral side of their knee, and they have a hard time kneeling. Is the meniscus being affected? Any suggestions?
Um, Probably tough to say without an MRI. I mean, wear and tear, like chondromalacia behind the kneecap, can cause a lot of pain with kneeling, when the knee's in flexed position for a long time. But probably tough to really give any guidance without kind of more information or looking at an MRI.
All right. Um, Another question about the shock absorber surgery. Um, how is it performed? What type of anesthesia?
So it's general anesthesia. Patients go to sleep. They're not aware of, the actual surgery when they're having it, but it's an outpatient procedure. So you still, plan to go home the same day that's a procedure.
All right, thank you. Does ablation where they burn the nerve work for reducing pain?
Yeah, so that can be an option. A lot of pain management physicians will do that. Usually that's done for patients that aren't candidates for, knee replacement for whatever reason. So it's not something I personally do, but certainly it's an available option. I think it has some data to support it.
All right, thank you. This person said they've had knee cysts for years, flare-ups with swelling and pain. Will they eventually destroy the cartilage?
Knee cysts, uh,
I don't know if I'm saying it right.
popliteal cysts.
Yes, popliteosis.
Oh yeah, so popliteal cyst is that's the same thing as like a Baker cyst. So again, that's just kind of for whatever reason the knee is irritated, whether it's arthritis, underlying issues with the meniscus, and fluid is kind of leaking out from the knee joint into the back of the knee. Um, so again, it's not something that I'm usually really aggressive treating. I know there are some people will aspirate under ultrasound guidance, but in my experience, usually they just come back without treating the underlying issue. But just because you're getting the cyst doesn't mean it's going to like destroy the cartilage. It's just representative of irritation in the knee.
All right, thank you. Is there any future with cartilage regeneration?
I mean, that's kind of the hope, the dream, I think. I'm not sure. Obviously, we're going to be there anytime soon, but if somebody could recreate cartilage and put a whole bunch of people out of business, and it would probably be a good thing for patients. So hopefully, but I don't think in the near term that's really a realistic thing.
Okay, thank you. What is the reason that a partial knee replacement is less common?
I don't know if there's one reason, probably training. Historically, I think there were some issues with longevity. Um, I mean, I think it's probably gotten better. It's not something that I usually do, but with the use of robotics, I think the cuts are more precise, and I think a lot of people who are doing partial knee replacements are using robotics to kind of make sure that it's in an appropriate position. Um, so it's probably just training, honestly.
All right, thank you. Great questions. There's still some questions about injections, I guess cortisone and gel. I know you touched on this. What is the max number of cortisone shots someone can get? I know there's, months in between that patients have to wait. Is there a, is there a max number in the lifetime that they
Uh,
can get them?
Yeah, not that I'm aware of. I mean, you can't get them any sooner than 3 months. So
Mhm.
some people will get in cycles where, they're coming in every 3 months. Gel injections you can do every 6 months. Some people will alternate. You do a steroid, then you do a gel, then you do a steroid, for example. But I mean, once you have arthritis, like I said, personally, I would keep injecting somebody as long as they want to be injected and until it's not effective or, they want another treatment. But as far as I know, there's no like lifetime, hey, you got it 3 times and you can't have it anymore. That doesn't really exist, at least for arthritis.
Gotcha. Okay. Thank you. Right. Sorry, just going through these. Thoughts on ligament saving knee replacement surgery? If,
Ligament saving.
yeah, I don't know what that person is referring to.
Um, yeah, I'm not 100% sure. I mean, there are different concepts for knee replacements. Like if you keep, you know, some of the cruciate ligaments or not. That again has never been proven to be better or worse. It just kind of comes down to training. So I mean, it's certainly there are some procedures or strategies to preserve some of those ligaments in the knee, but again, not better or worse.
Gotcha. Okay. All right. Looking for some different questions here. Sorry. Apologies if we don't get to all of the questions. Some of these are a little specific, so we're kind of just looking for more general questions that can be applied to anyone. Dr. Prater, you mentioned 85% satisfaction on a knee replacement. Do you know what the satisfaction rate on that shock absorber treatment is as of yet? I know
I don't know if I
fairly
can
new.
quote a number like that. I mean, I think again, that one graph I showed, like 95% of people have shown improvement that's sustainable for 5 years out. So I'm not sure that's really translated to satisfaction rates like are quoted for hips and knees. So I'm not sure I can really give a specific number.
All right, thank you. Question about, I don't know if you've ever heard of this treatment, microfragmented adipose transfer treatment. Have you heard of that? MFAT?
Um, Not specifically that. I mean, there are, like we talked about, the different types of injections. There are adipose like stem cell injections where, adipose tissue is already differentiated kind of along the mesenchymal stem cell lineage. So, you can take out fat, you can spin it down on a centrifuge, and then you can inject it back into joints. There's actually pretty good data to support that for improvement in pain related to arthritis. So it's probably something like that. And again, if there's definitely evidence to support that.
All right, thank you. A couple questions about age restrictions for knee surgery, knee replacements. I don't believe that there is. I think it's really based on the health of the person, but if you can touch on that.
Yeah, I don't think that there's definitely not an age cutoff. Everybody's different. Some people who are, every 75-year-old person is going to be, not the same. Some people are very active, some people are not as healthy. So I think it's more individualized. But yeah, there's no like hard and fast age number.
All right, great. I think we answered most of the general questions. Apologies again if we didn't get to all of them, but thanks, Dr. Schrader, for that great presentation and for answering all of the questions. And again, thanks everyone for joining this evening. Several questions about if this is will be available after. Yes, we recorded this. It will be on our YouTube page. It will be on our website under Dr. Schrader's profile page. So feel free to look there. We also will be emailing it out to everyone who registered and joined tonight. So again, thank you so much, and thanks so much for all that information, Dr. Schrader.
Thank you.
All right, have a great night, everyone.
Bye.